Rigopoulos.
Thank you, Mr. Chairman. I would like to thank the organizers for inviting me to this exciting Congress. I have no conflicts of interest. And of course, we are not electrophysiologists but we need to think about the possible need for permanent pacemaker implantation after TAVI. And at first, we'd like to see a little bit of the anatomy of the aortic root, which the surgeons know very well. Well, the penetrating bundle of His emerges at the surface of the left ventricular outflow tract, exactly beneath the membranous septum. And this we should be aware of, because this is our landing zone with the TAVI valve. And the length of this membranous septum is approximately equal to the distance between the aortic annulus and the bundle of His. So, of course, we know that about 15% more or less of our patients will need a permanent pacemaker. And if we look at the TVT registry data, we see that although the number of implantations during hospitalization is slightly reducing until 2018, there is an increase in the number of patients who will need a pacemaker after discharge. Well, newer data of the same registry show that overall the need for a pacemaker is reduced, and this is until 2020, perhaps due to the awareness of the need for a permanent pacemaker implantation in the patients. And, but there are differences in centers which do not have anything to do with the volume of the procedures in each center. So if we look at the data from this registry, the PACE-TAVI registry, with 377 patients, we see that the more the patients are getting paced by the pacemaker, the more problems we have with cardiovascular death and hospitalization for heart failure in follow-up, and this is up to 5 years. And what is more, we see that patients with reduced ejection fraction before TAVI that will take a pacemaker, that have a pacemaker afterwards, will have less improvement in the LVEF after TAVI, while patients with normal EF might have a reduction in EF at 1 year. And this is, of course, seen also in the symptoms of the patients, with patient having more than 40% ventricular pacing, having more symptoms. And this is a meta-analysis which included more than 50,000 patients, and here we see also that mortality and rehospitalization is increased in patients receiving a pacemaker after TAVI, while there is no difference in stroke or endocarditis in comparison to the patients who will not need a pacemaker. So although not everyone agrees with that pacing is bad for our patients, we have these data and we should believe them. What are the most common conduction problems after TAVI? First, we have the left bundle branch block, which is in different studies from 5 to 65%. It slightly decreases with the use of modern prosthesis. Typically, we see that during the intervention and rarely after 30 days post-interventionally, and very often it is transient. But if we see it longer than 30 days, then we should call it permanent. And it is extremely likely that a patient with a new left bundle branch block will need a pacemaker if the patient has a right bundle branch block before the intervention. The other most common conduction problem is the atrioventricular block. It's about 20% after TAVI, and usually happens immediately during the intervention or just after the procedure, and often resolves on its own But there we need a little bit longer temporary pacing for our patients in order to be sure that it has resolved and the patient is safe. But if the block does not resolve, then we need permanent pacing, and there are of course some cases with late or delayed high-grade AV block which could possibly explain syncope or sudden death after TAVI. What we must know is that the risk of a delayed high-grade AV block is in sinus rhythm patients if we have a persistent new LBBB or prolonged QRS or PR interval, and in atrial fibrillation patients if we have consistent bradycardia, constant bradycardia less than 50. So there are some predictive factors that could increase the risk of a patient needing a pacemaker, and they have to do with anatomy, pre-existing ECG changes, technical things like balloon dilatation of the prosthesis, the choice of the prosthesis, or oversizing, implantation death, and of course calcification of the aortic root. So if we see one by one, there are some demographic predictors. Possibly male sex is a predictor of need for pacemaker. Male patients need a larger prosthesis, but we need less frequently to oversize, and this is probably a weak predictor. Age is also a possible predictor, older age. Increased BMI is also a predictor. We don't have here an obesity paradox. And possibly patients with renal failure have also a higher risk. On the other hand, if we see the ECG and computed tomography predictors, a short membranous septum, as said, less than 8 millimeters is a predictor for permanent pacing, and the distribution of calcification and the size and shape of the LVOT and annulus may also play a role. A pre-existing RBBB, as said, is a very important predictor, and of course if we have prior abnormalities of the AV conduction, this also increases the risk. Peri-procedural factors, as said, is the valve choice. We had the Lotus Edge valve, which is not anymore in the market because of a high pacemaker implantation rate. And with the self-expandable valves, we have a higher need for pacemaker with a pooled incidence of 25% in older studies, and certainly higher than the balloon expandable valves. This is because of the, more or less because of the deeper positioning in the older times of these self-expandable valves. And with the balloon expandable valves, perhaps there is a higher risk of pacemaker need with the Sapien Ultra because of the outer skirt. But this we still have to see. With the Accurate Neo, there's a very low need for a pacemaker, probably because of the reduced radial forces and the supraannular position of the valve. And generally, with larger valves, more than 29 millimeters, we need probably more pacemaker implantation. The depth of the implantation of the valve, of course, is a very important reason because it has a direct relation with the need for pacemaker. And of course, the most important factor is the difference between the length of the membranous septum and the implantation depth. The post-dilatation increases also the rate of need of pacemaker, and as said, the ECG changes should also be considered. There is a risk score with a very good, predictive accuracy, which involves the device landing zone calcification with a precise characterization of distribution of calcification in aortic valvular complex, the short membranous septum length, the pre-existing right bundle branch block, and the ventricular implantation depth of the prosthesis. And we see that this has a very good negative predictive value, this risk score. And of course, if we have all three or all four factors, then we have a very high need for permanent pacemakers. This should be validated in further studies. So what we have to do, as said, we should avoid excessive oversizing and of course undersizing, because then we will have regurgitation. We need sometimes, as Dr. Georgiou showed, to make some compromise decision between the need for a pacemaker and the risk of coronary ischemia, and then of course we decide for the pacemaker. And of course, we need nowadays to lower the implantation, to put the valves higher with the Midas approach or the cusp overlap technique. This is the Midas approach. They measure the length of the, with the CT, the length of the membranous septum, and then they try to position the valve a little bit higher so as to not interfere with the His bundle. And the cusp overlap technique we have seen in the last years, we implant the valve as high as possible, judging from the non-coronary cusp. And you can see in an old patient of ours with a pre-existing conduction problems in ECG and a very low left ventricular ejection fraction, after almost 2 years, the measurements in the ECG have become better than before the implantation, and the patient is doing fine. We have results from this meta-analysis for the cusp overlap technique, which showed that really we could implant less than half of the patient's pacemakers after using this technique. And then the question is, what happens if we really have abnormalities with conduction after TAVI? What we do then? We have the guidelines, the ESC guidelines of 2021, and we see that there are some cases, and then we have to decide according to what we have with the patient. If we have a persistent high degree AV block, meaning at least 24 to 48 hours after TAVI, or a new onset alternating bundle branch block, then of course we need a pacemaker. This is easy. If we have a pre-existing right bundle branch block with new procedure conduction disturbance, meaning transient high degree AV block, PR prolongation, or an axis change, then we need also a permanent pacemaker. This is a class 2A indication. And now it begins to become a little bit difficult. If we have a persistent new left bundle branch block with QRS or PR prolongation, and no further prolongation in the first 2 days after the procedure, then we may monitor the patient with ambulatory ECG monitoring or perform an EPS to measure the HV interval. Of course, a high risk for high degree AV block in a new onset LBBB is the existence of atrial fibrillation, prolonged PR, or a low left ventricular ejection fraction. And last, if we have a pre-existing conduction abnormality with further prolongation of QRS or PR interval more than 20 milliseconds, then we also need to monitor the patient with ambulatory ECG monitoring or perform an EPS. This is here a 2B indication, and of course with no further prolongation of QRS or PR during the 48-hour observation. Otherwise we would fall to another category. The new LBBB is not so benign. Of course, we see it very often, but if in this study, the patients were followed with ILR reveal for a year, and they saw that many patients had, about half the patients had arrhythmic events during follow-up, and 11% of those would need a pacemaker or ICD. On the other hand, here is another study from the Mayo Clinic, and they showed that the patients with a new LBBB needed a pacemaker, 14% needed a pacemaker because of progressive AV block in 30 days. So we need to look after those patients, although the patient is not anymore in the hospital. We are not electrophysiologists, but if the electrophysiologists are asked what to do in cases of new or pre-existing LBBB after TAVI, or patients with other... it's the last one. It's the last one. Then there are various answers, and this might be explained due to the differences in the guidelines between USA and Europe. So in conclusion, conduction disturbances remain a concerning complication after TAVI, and permanent pacemaker implantation is, however, associated with higher risk for mortality and rehospitalization. Patients will need continuous ambulatory ECG monitoring in order to have them safe and decide if they need eventually a pacemaker. Of course, we have some progress with the prediction for the need of permanent pacemaker implantation, but still this is an unmet need, and perhaps we have some gaps in evidence. We have to recognize the anatomy of the membranous septum, and probably we need to involve the measurement of the length of the membranous septum in the MDCT measurement protocol before TAVI, so as to decide for the corresponding optimal implantation depth in our patients. Thank you very much.
Thank you, Mr. Rigopoulos. Unfortunately, we will have to proceed to the last